Good evening. My name is Roxanne Chabot from RBC Consultants. Welcome to our webinar on a practical algorithm for the use of supportive skincare to improve patient outcomes and satisfaction with non-energy and injectable dermatological procedures. This evening, as speaker, we have Dr. Lisa Ginn, who is a board-certified dermatologist, fellow-trained laser surgeon, and founder and principal of Skin at LRG in Chevy Chase, Maryland. We also have Dr. Ted Lane, who is a board-certified dermatologist, chief medical officer of Sonova Dermatology, and executive director and principal investigator at the Austin Institute for Clinical Research in Austin, Texas. We'd like to thank our supporter, SkinCeuticals, for making this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues or if you would like to ask a question to our faculty, please submit your questions in the question chat pane on the right-hand side of your screen. At the end of this webinar, a survey will pop up in your browser and will be emailed to you 1 to 2 days later. We greatly appreciate it if you could fill it in and send it back to us. And within 1 to 2 days of the webinar, a certificate of attendance will be sent to you, as well as the recording of the webinar that you can re-listen to at your leisure. Again, please submit your questions using the question chat pane on the right-hand side of your screen. And I wrote a little note there so that you can see where you have to write the questions for our faculty. So without further ado, I will pass the floor virtually to Dr. Lisa Ginn.
Hello, good evening, and thank you for joining us today.
Dr. Ginn, if you could click on your camera and the little gray camera there. There you go. There you go.
Good evening, and thank you for joining us. Okay, we're going to start with a poll question. Our poll question: skincare, when integrated effectively with facial, non-energy, and injectable anti-aging treatments, can achieve the following: reduce post-procedural downtime, improve comfort during and after treatment, stimulate post-procedure healing, improve treatment outcome, or all of the above. You can now submit your answer. And really, we're trying to determine, once we remove all the smoke and mirrors, how much can we really achieve with topicals? How much are they able to really assist with our procedures? Alrighty, so 100% have voted all of the above. And that's correct. Let's find out why and how we achieve that. So our focus this evening is going to be on pre and post care recommendations for facial procedures performed with non-energy devices, meaning no laser, no light source devices, and for injectable treatments. We'll present and discuss what we believe to be a very practical algorithm to guide physicians in determining best peri-procedural skincare protocols. Now, why is this important? Well, when we look at the market in the industry of medical aesthetics, we notice that for facial rejuvenation and anti-aging treatments, these non-energy devices and injectable treatments are among the most rapid in growth. Patients are asking for these treatments, and they're fairly easy to incorporate in our practice. Unfortunately, even with all the growth in the industry with these treatments, there really isn't any standardized recommendations that we could find to date that really provide us with guidelines on how to best integrate products with these treatments. We're going to produce an algorithm and discuss that tonight that, again, will help guide us in learning the best protocols to integrate these skincare products to achieve stimulated healing, reduce downtime, improve comfort and treatment and outcomes. So when we look at the exosome, That's really the combination of external and internal factors that trigger skin aging. I think we're all familiar with solar radiation, climate, and I think it's important when you're getting your history from patients to not just look at where you're treating them, where they currently live, but their history as far as where they grew up, because most of the damage has happened years ago. Pollution is a growing factor that we're becoming more aware of and learning more about. Stress and psychological factors. This is huge, especially post-COVID. COVID has taken its toll on all of us, and as survivors, we tend to minimize it, but the impact of stress on the aging process cannot be minimized. Hormonal variations, we all experience them. I think women are more familiar with this than men, but stress and hormonal variations are huge contributors to lack of sleep. Drugs, alcohol, and tobacco can't be stressed enough, and diet and nutrition is really interesting component that we're learning more about as time goes on. So when we look at UVA and UVB, we know the effects in skin. UVA, of course, goes deeper than UVB into the dermal layer, and it has a profound effect on collagen and elastin. Together, UVA's damage to the dermal layer and UVB to the epidermis result in skin tanning, age spots, and wrinkling, and contribute to, unfortunately, the development of cancer. How this happens, oxidative stress and skin damage. This is a big topic. When oxidative stress process happens, we know that oxygen in its natural state normally undergoes metabolism, and the end result is reactive oxygen species formation. Now, this is beneficial. It's necessary for homeostasis and cell signaling, but when the stress level is high, these oxidative species dramatically increase, and that results in cell damage. I explain this to patients as saying, I think of oxygen is the hopeless romantic. Oxygen is a natural state. It's two oxygen molecules intimately bound together. And when we have this environmental stress, that oxygen molecule will separate. And so we get O negative and O negative. And oxygen desperately wants to be paired with a mate. Unfortunately, one of its favorite choices is collagen in the dermal layer. So when this happens, we have collagen breakdown, loss of elasticity, and uneven pigmentation. And so that's why antioxidants have become so big and are so important in a skincare regimen, because they help combat the effect of these reactive oxygen species. Why are energy and injectable facial anti-aging treatments so important? Well, to some degree, we all suffer from photo damage and chronological aging, depending on culture, ethnicities, there are varying degrees of how much that occurs, when it occurs, and how much it negatively impacts our quality of life. But for the most part, none of us want the effects of unchecked aging. So depending on your patient's characteristics, expectations, your expertise as a physician, and what modalities you have available to you, that all comes into play with what you'll choose and how much you can help your patient. Again, with these non-energy based devices, when we have them available to us, having some type of standardized recommendation on how to integrate integrate them with your treatments becomes really important. So many of these treatments have so much variability. We want to offer some standardization. When we talk about these treatments, we're really talking about neurotoxins, Botox, Dysport, Xeomin, fillers, both hyaluronic acid based as well as those that are not, threads, chemical peels, microdermabrasion, microneedling, those are really gaining popularity. And frequently patients will choose these treatments because they view them as having little to no downtime. They're minimally invasive, and the risk should be much less than with ablative laser and surgical modalities. So when we look at the market over the last few years, we noticed that neurotoxins, Botox, Dysport, Xeomin are really leading the marketplace. I personally think this is because they're so predictable when performed in the right fashion. You don't have to change your technique depending on the patient's ethnicity, and you can treat so many areas of the face as well as areas of the body. When we take out treating the body with contouring and cellulite treatment, the next two are chemical peels and impulse light, IPL. Now, these are ubiquitous. You can find them just about anywhere. And a lot of times when starting out physicians or providers will say that these have the least amount of risk, and that's not true. Chemical peels are not regulated, so that means that they can change from lot to lot and from batch to batch, and if they're underlying dermatitis can be exacerbated. So just make sure that you really know the product that you're using. And IPL, in my personal opinion, is not meant for patients with richly pigmented skin or those that have a tan. With all that we know, the data remains very limited on best practices for aesthetic procedures. It's very limited, and so we decided to look to see what we could find in the literature. When we look worldwide, I think it's really interesting that we see North America is leading the world with these treatments. Europe is not too far behind, and Asian Pacific countries are very close to that of Europe. But if you look at the growth rate, we see that Asian Pacific countries are really leading the pack. They're really catching up with a lot of these treatments. I personally think that as physicians, it's great if you can visit these other countries and learn different technique. I try to make a point of going abroad at least every other year to visit congresses and conferences abroad, because you learn different techniques, you learn how they do different procedures. Some of that you can come back and integrate into your practice. And in this day and age, with diversity, equity, and inclusion being so important and on everyone's radar, it helps you identify with patients from different ethnicities to know some of the trends in their countries to be able to offer them a variety of treatments. We kind of categorize these treatments into 4 major groups. Topical skincare devices. So we're talking about creams, ointments, serums, gels that patients can not only use at home, but you can incorporate in your in-office procedure. I tell patients this is like your daily diet. Don't minimize what you can do with your skincare. And when they're incorporated and integrated and paired with treatments in the office, you should have not just a synergistic effect, but an augmentative effect. It really should help your results from the procedure. Mechanical devices, as we said, microneedling is now really one of the #1 things we do. And if you think about it, just a few years ago, microneedling wouldn't be found in a dermatologist or plastic surgeon's office. But now microneedling has become very popular for a multitude of reasons and leads this category with microdermabrasion. Lasers, you know, I'm a laser surgeon, so lasers are king to me, but they do carry a lot of risk for certain patients and a lot of investment for us to have for our offices. And then of course the injectable treatments are extremely popular. Dermal fillers and Botox are the most commonly sought after by patients. So now we're going to turn to our algorithm, a little bit on the literature search that we used as a basis and what we concluded. So again, our algorithm is designed to stimulate healing and improve comfort and treatment outcomes when these products are integrated properly with your in-office procedures. Side effects. So when we looked at the literature, we found that most articles dealt with how to reduce adverse events, and this is important, but few algorithms exist on skincare integration with your in-office procedures. And so when we look at adverse events, that can lead to some of the major things are like prolongation of the duration of healing and severity of the healing process. Signs and symptoms can last anywhere from as few as a few days up to several weeks. This is important because we market a lot of these treatments as no downtime, you know, lunchtime procedures, and patients more and more live busy lives. And at least the area that I practice in, patients don't want to have much of an impact on their social or their work schedule. When we looked at the data, we looked from 2010 to January 2023. We used PubMed, Google Scholar, limited to the English language, and then these articles were reviewed by physicians and or physician scientists, and then they were categorized into the following categories. So we had group 1, which really dealt with those adverse events, primarily hyperpigmentation and hypopigmentation. And then group 2 dealt with the integration and pairing of these topicals with in-office procedures, both pre, during, and after. So we had 54 articles, 24 were excluded because they were poor quality studies. And then we had 30 remaining. Most of these papers actually dealt with preventing and minimizing adverse events. For those that dealt with pairing procedurally of skincare products with the treatments, A little less than a fourth were very small clinical studies, 2 consensus papers, and only 2 algorithms. 19 of the studies really didn't pertain to this topic. So our algorithm is divided into 4 sections. We have pre-treatment, which starts anywhere from 2 to 4 weeks before the procedure. The treatment section itself, meaning the day of the procedure, aftercare beginning immediately after that night to the first week, and then follow-up care weeks 1 through 4, so about a month after treatment. Here's our algorithm. Starts with a good medical and dermatologic history, and then there are 2 arms. They're non-energy procedures, chemical peels, microneedling, dermabrasion, and then the injectable treatments. And so what I'd like to do from this point on is we're going to look at each section individually. So the first being the medical and dermatological history. This I can't stress enough. We want to set realistic goals for patients. And to me, that's not only telling patients what they should expect to see after the first session, but being very forthright and letting them know that a lot of these procedures require multiple sessions. So say if it's a series of 6 or 8, I like to tell patients this is what you should expect after the first session. I let them know that's a cumulative effect. And if there is a dramatic increase, say after the forced treatment, to let them know so they don't get discouraged with the first few sessions. In addition, I let them know as they're undergoing these treatment sessions that we're going to check in and reassess after the 3rd or 4th session. A lot of these treatments are not performed by us as physicians, but by other staff members. And so it's nice to have a benchmark so that you can really check in to see how the patient is doing, and you still have time to alter before they finish their series to get the most dramatic results. I always ask, what procedures have you had performed prior to visiting my office, because I want to know what they liked about those procedures and what they didn't like about those procedures. When it comes to their medical history, it always amazes me what patients will leave off of their intake paperwork. So I want to know everything that they take by mouth. I want to know anything about their history, medical conditions, underlying allergies. A lot of times patients will say, well, I didn't think that was relevant to this. And I tell them, that's not for you to worry about. Let me be the person who judges and guides you with that. And then lastly, we need to look at Fitzpatrick skin type so we can see who's at greater risk for hyperpigmentation. One thing that I like to share with our group today is that I treat about 50% Caucasian, 50% patients of all ethnicities. And what I find anecdotally is that if you're treating a patient of color, it's helpful to ask them if both mom and dad are about their complexion, or if one parent is significantly lighter in skin color and if the other is a richer pigment. I find that the patients who have that diversity with their parents are at slightly greater risk for hyperpigmentation. So here's our algorithm. We've already discussed at length here the medical and dermatologic history. And next we're going to go to pre-treatment. Ideally, all patients, in my estimation, should be on pre-treatment. It gets a little tricky if they're flying in that day and want to have a same-day procedure. But other than that, we want them to be, for our non-energy procedures, on a gentle cleanser, one that is close to the skin's natural pH, so slightly acidic. Moisturizers are not meant to be action products in our estimation. There should be gentle, oil-free, and ones that won't flare any underlying dermatitis or diseases like acne. Sunscreen, we want to push hard. We want patients, no matter what their complexion, to be as close to their natural skin color as possible. So an SPF of 50 is ideal. And then you have antioxidants, which, depending on what you're trying to achieve, antioxidants are great in assisting in achieving those results with these devices. Soothing agents, hyaluronic acid, botanicals, anti-PIHP ingredients, be it hydroquinone, or natural lighteners and anti-redness ingredients for erythema-prone skin. And I'm going to revisit, especially these last 3, when we get into the section about post-inflammatory hyperpigmentation and minimizing those. So when it comes to injectable procedures, basic cleanser, moisturizer, and then you can kind of choose out of the antioxidants, soothing ingredients, PIHP preventers, and anti-redness. I personally think that when you're treating with injectables, you're kind of focusing on a specific issue the patient has. But once you have cleared that with your injections, oftentimes it's kind of like a smudge on a window. Once that's clear, they'll start to notice other imperfections on the skin. So I tend to recommend putting patients on a full regimen. So as the wrinkles, the furrows are properly treated with your injectables, the entire face is clearing. And we have data support that patients tend to perceive that they have a better result when you treat the entire face. So what are we recommending for our injectable treatments? What are we using these days? Well, we can see the neuromodulators are still the #1 thing requested by patients, but HA injectable treatments come very close, and then your non-hyaluronic acid injectables are third. The rest are fairly low. When we looked to some of our leaders in the field, Mitch Goldman and colleagues looked at what he could find in the literature, doing a survey on what we're doing when it comes to these peri-procedural topicals, and there was really no consensus. We couldn't find any real support for standardized recommendations. Likewise, when they looked at what we're doing when it comes to injectable treatments, there was, again, no consensus on recommendations for integration of these skincare products with your injectable treatments. As far as what we do recommend for our patients to avoid before injectables, aspirin is almost universal. And then sunscreen is almost universal, but aspirin and NSAIDs are also, we tend to recommend that patients avoid those, of course, for the risk of bleeding. Facials facials are in the top 4, and I like to say with facials, we really don't know what patients are being exposed to when they get facials. And again, patients will often get a facial if they're not warned to avoid that right before they have a procedure and in these injectable treatments, thinking they're prepping their skin for it. So I think it's important to tell patients to please avoid any procedures, including facials, beforehand. With our dietary supplements, the data is all over the place with this. And as a former medical officer with Food and Drug Administration in the division that regulated dietary supplements and cosmetics, I tell patients, please do not take anything that's not medication and needed before procedures. We just don't know what these different dietary supplements, how they can affect the procedure and our injectable treatments. Inflammation and pigmentary disorders is huge because we know if you treat any patients of color, you're constantly worried about trying to minimize the risk of hyperpigmentation. Unfortunately, hyperpigmentation and hypopigmentation can result from a variety of things, including inflammatory dermatoses, skin injury, and photo damage. Inflammation can be triggered by various stimuli, including, as we see in the diagram, UV rays, chemicals, pollutants, and injury. And inflammation is a necessary part of the healing process. We know that cytokines are released by epidermal keratinocytes, dermal fibroblasts are involved, and so all of these things result in increased melanin formation. Post-inflammatory hyperpigmentation and hypopigmentation are very difficult side effects that we want to avoid. And again, another little pearl that I have for my colleagues is that when treating skin of color, oftentimes it's hard to see erythema, but erythema resulting from inflammation really needs to be minimized. I'm a firm believer that erythema immediately after treatment tends to lead to hyperpigmentation. So we want to minimize erythema, while inversely we want to maximize hydration, soothing botanical products, hyaluronic acid. The more hydrated you can have skin of color, the less likely you are to get hyperpigmentation. A general rule I say, if skin of color is dry, it will not give up hyperpigmentation. What do our colleagues do when it comes to preventing hyperpigmentation? Well, about 2/3 say that they use products to prevent it, but a third say yes, but 2/3 say no. This is important, as well as what we're choosing when we're trying to prevent hyperpigmentation. The vast majority still lean towards hydroquinone, with only about a third choosing non-hydroquinone products that inhibit melanin formation. I tend to like those natural lighteners because you don't have to worry about some of the side effects or precautions that you do with hydroquinone. What advice do you give to patients pre-procedure? Well, when we look, we see that arnica and bromelain are pretty common. I love arnica and bromelain to give to patients to minimize bruising and result in hyperpigmentation and downtime, as well as tretinoin for some, and hydroquinones or lightening agents. So as we look at the algorithm as it relates to hyperpigmentation, hypopigmentation, we go back to that component of antioxidants, soothing ingredients, especially anti-PIH ingredients and anti-redness. So even if a patient doesn't appear to have any issue with erythema or sensitivity, I think it's great to put patients on those topicals as part of their pre-treatment regimen. Last part of the algorithm that I'll cover is what to do once the patient is in the office and ready for their procedure. When it comes to removing makeup, disinfectants, and numbing, I think it's important to standardize what you use in your office, not just the agent that you choose, but how it's applied. We as physicians tend to use gauze, but if you have estheticians doing these treatments, they tend to rely on cotton or cloth. So you want to make sure that everyone is using the same method of removing makeup and cleansing the face. And when we look at agents that we use, isopropyl alcohol remains at the top, but chlorhexidine, of course, is a nice go-to. The one caution with chlorhexidine, of course, is caution when using around the eyes because of the risk of corneal abrasion. We're now going to turn to Dr. Lane as he takes us further into the algorithm, data, and products.
Lisa, thank you so much. That was wonderful. Every time we've practiced this, and every time we've done this, she's given more and more pearls, and I learned something each time. So thank you, Lisa. So I'm Ted Lane. I'm a dermatologist in Austin, where it is hot and always sunny, and we have to deal with PIH all the time. So I just thought we'd start off with this quick poll question. How often do you recommend particular skincare products, ingredients, or a skincare regimen after you perform an injectable procedure? Always, often, sometimes, or never? It's interesting because, you know, when we got together as a group to kind of come up with this algorithm, I'm not sure we had really thought about skincare after an injectable procedure, but we're starting to see more and more data come out about skincare with injectables, and so we need to. But I'm just interested to see where this group lands. Yeah, kind of all over the map. I'm surprised that almost half of the people said always, which is great, and I think we have data to support that. So let's go right into that. Okay. All right, so just wanted to kind of set the baseline here. Remember, we've just talked about pre-treatment. Now we're at treatment and beyond, kind of that blue oval and beyond. Of course, during treatment, makeup removal, disinfectant, you'll use numbing. And then we're going to talk about aftercare and then follow-up care as needed. So during treatment, of course, the treatment for pain and anesthesia for non-energy or injectable devices should be at the treating physician or provider's discretion. Depending on the patient and the type of treatment administered, we really couldn't come up with a recommendation beyond something that general, because there are just so many different non-energy based device treatments, as well as injectable treatments. And some people like numbing, some people don't like numbing, some people find that it swells a little bit. So you just really couldn't come up with the general, we came up with something very general, okay? But the 0 to 7 days post procedure is something that we really do need to talk about, okay? Because, you know, depending on what you do, you could use something really gentle. I'm going to go back real quick here. You can use something gentle. So we have two boxes there, and I don't want you to think about these boxes as kind of in a silo, okay? I know they're boxed and it looks like this is the only recommendation you have for either on the left non-energy based devices or on the right injectables, but honestly, these are considerations for you to choose from for the patient in front of you, okay? So if you have done a non-energy based device, let's say you've done a medium depth peel, well then you're probably going to be more on the right than the left, okay? You're probably going to be using more basic skincare, skincare with hyaluronic acid, for example, maybe a topical corticosteroid to decrease inflammation, and you may do that with your, you know, immediately after your injectables as well. But if you've done a kind of a lunchtime, you know, 10-15% glycolic or salicylic acid peel, you very well could be on the left, where you are immediately using something with glycolic acid. You want, of course, an oil-free or gentle moisturizer, sunscreen for everybody, but you may feel like it's time for you to start retinol very quickly, or other skincare products that the patient may have been on previous to the treatment that you think you could start very quickly. I mean, we have data, for example, with CE Ferulic, which is a SkinCeuticals product, but CE Ferulic right after an ablative laser treatment, a CO2 laser treatment, where it was used the day of, and we see not only a decrease in downtime, but we also see an increase in beta fibroblast growth factor to increase collagen production. So yes, it's an acidic product. It has to be in order to stay stable, but it was tolerated immediately after an ablative CO2 treatment. So I think we need to get into the mindset of we don't have to be so basic for even some of our more advanced or invasive non-energy based device treatments. I know I just talked about ablative laser, but you get the same idea with the chemical peel, for example. And perhaps we should push the envelope a little bit in terms of the topicals that we are applying, even in the early days after the procedure. Now, let me keep going. So, okay, you want to make sure you're using non-comedogenic cleanser. We talked about all of this. Topical retinol as soon as possible. Remember, in some cases, you may have either completely removed the stratum corneum or damaged it to the point where you are able to increase the penetration of topicals, including retinol or antioxidants or hyaluronic acid. Whatever you have, you could probably increase the penetration of these. So take advantage of that, because at that point you'll be able to affect more change. And that's the whole idea of integration of skincare with your procedures, right? The idea is take advantage of what those procedures have done to the skin to enhance the penetration of the skincare so you can enhance the outcome altogether. Now, obviously not the case for injectables, okay? For injectables, you're trying to decrease downtime, decrease swelling, bruising, whatnot. But on the other side, for the non-energy based devices, guys, we need to take advantage of the data, and the data tells us push the envelope a little bit, but be careful to try and improve and enhance the outcome for our patients. And that's what these companies are doing. They're coming up with these wonderful new products that have active ingredients that are suitable for post-procedure, that can penetrate better, but are gentle enough that it won't cause some of the issues that we are concerned about: the increased inflammation, the risk for PIH, the prolonged downtime. Indeed, now we are at the point where skincare can not only affect change, but decrease downtime as well. When we're talking about dyschromia, remember, for our richly pigmented skin, Dr. Gold et al. Came out with an algorithm in 2020 that talked about perhaps starting with arnica and bromelain either as a supplement or with fresh pineapple, to prevent dyschromia in richly pigmented skin types either prior to and immediately after the procedure. Other products that can treat dyschromia include hydroquinone, of course, niacinamide, kojic acid, licorice root extract, azelaic acid, to name a few. And Dr. Ginn already said that she preferred the non-hydroquinone ingredients because you don't have to worry about some of the side effects, which may at this point include an increased risk of skin cancer with the hydroquinone. More data needs to come out on that. Michael Gold also led this algorithm with Andrew Alexis et al. For racial and ethnic populations treated with facial lasers, non-energy based devices, and or injectables. And it says here, pre-procedure consultation on just to meet the individual patient goals is important. Before the procedure, sun avoidance, sunscreen are emphasized, HSV1 prophylaxis, and bleaching agents are administered if indicated. It doesn't say in every patient. It says if indicated. During the procedure, you use judicious techniques to minimize unintended cutaneous injury, and then post-procedure sunscreen, gentle skincare that may include skin lightening ingredients or formulations designed to prevent infection are advised. In our group, we said, look, not every patient with richly pigmented skin after an injectable procedure needs to be treated with prophylactic bleaching or lightening agent, because it's rare that we actually see that with injectables. And so that's why I think you see here that it is not a blanket recommendation for richly pigmented skin. But here, what do you use to treat post-inflammatory? And it's all over the map. We have topical steroids, probably high potency topical steroids. Topical hydroquinone is, of course, number one. Combination steroids with hydroquinone, perhaps Kligman or modified Kligman there. And topical non-hydroquinone pigmented corrector products are there. I think now, with the advent of these novel formulations that have either novel ingredients or novel combinations of ingredients that are non-hydroquinone based, showing efficacy that is similar, if not superior, to at least 4% hydroquinone, we are able now to get away from hydroquinone, to Dr. Ginn's point. And so use the newest products that are available because they are the ones that have the data to support them as compared to 4% hydroquinone. There are lots of great studies being put out now by wonderful companies, both large and small, that can help you in determining which product you'd like to use to reduce the risk of post-inflammatory hyperpigmentation and or to treat the hyperpigmentation that has already occurred. And then we're talking about bruising. How do you deal with bruising? You've got pressure, of course, immediate pressure can help, ice as well. And then it's, you know, we're looking at aloe vera, ice, heat, vitamin C cream, PDL, V-beam, of course, can be very helpful post injectable, and then elevation in vitamin K. So that's kind of all over the map as well. Let's just go into some studies that informed our decision-making process for the algorithm that we came up with. This is a wonderful study because, again, it shows that being a little bit more aggressive gets you better results. So all of these patients had toxin and at least 4 mLs of hyaluronic acid injections. And then there were 3 groups. 2 of the groups had an advanced brightening system, so skincare meant to brighten the skin. So cleanser, antioxidant, exfoliator, retinol, and a sunscreen. So basic good skincare, right? Group 2 had that skincare plus a series of 6 alpha hydroxy acid peels every 2 weeks. And then group 3 was the control, which is just cleanser, moisturizer, sunscreen. And what we showed was that the greatest blinder evaluated global aesthetic improvement scale, so the GACE improvement, global aesthetic improvement scale improvement, was with group 2, which was the one that was most aggressive, the one that had the peels along with the skincare. So this is the idea of patients want to get better. They want improvement, and we can be a little bit more aggressive. And so again, corroborates with the subject's perceptions that the more aggressive treatment yielded the best results. And that's exactly what we saw there. Then we see 2 other integrated skincare. We have one with a novel hyaluronic acid serum that was paired with a toxin treatment around the eyes for the periorbicular lines. And we showed that the HA containing serum actually did improve results compared to the toxin alone. And then we have a novel peptide serum that was meant to show to decrease bruising. And indeed, with this novel peptide combination, they did show a decrease in bruising with this novel ingredient and novel combination of ingredients. So showing you here that the data can inform your decisions as well. You just have to keep up with it because there's so many new products coming out. And that's what we were trying to do with our algorithm, is kind of help lead you down the path of using this new data. Here's a really interesting product, Phyto A+, which is a 3% azelaic acid plus 2% arbutin and 5.75% phytobotanical blend, used in a 12-week study with 64 female and male patients. Applied twice daily with a sunscreen, and multiple metrics of skin beauty and skin health were assessed by an experienced investigator. And you can see here, week 4 on the bottom, week 12 on the top, we see improvement in brightness, hyperpigmentation, and PIH. And then here we see clear, okay, pictures, we love photos, right? So here we see improvement in the clearness of the skin between baseline and 12 weeks, okay? You can see how the radiance of the skin is also improved there, how the light bounces off. Here we're showing it smooths the skin, so the reduction in appearance of pores, tactile and visible smoothness also improves with greater usage. And we see here, let me see if I can get there. With this patient, the greater smoothness, the reduction in the appearance of the pores, visible smoothness, tactile smoothness as well is improved. And here we're seeing clarify, so the skin looks clearer. Again, the light shines off, and we see improvement from 4 weeks even through to 12 weeks. And you can see with the sebum reduction also decreased by over 25% using a sebumeter. So more objective analysis on the sebum reduction. And that may correlate with pore size. As we reduce the pore size, the sebum goes down. And here we see a clearing of the skin. Also, you can see the pigmentation, the post-blemish marks are all improved here as well. And then we're looking at soothing the skin. Maybe we don't necessarily think of arbutin or azelaic acid as soothing the skin, but certainly the Phyto blend soothes the skin. And we see a really magnificent reduction in the redness here from baseline to 12 weeks. When we look at how well this Phyto blend decreases inflammation, this was an in vitro study where TNF-alpha was added to human keratinocytes, and the idea was how much inflammatory cytokine was produced, and that the marker for that was IL-8. When TNF alpha was used as a baseline, and kind of everything was compared to the TNF alpha induced IL-8 production. We see that when we add the single ingredients of the phyto, we decrease the IL-8 gene expression, but with the combination, just to the second from the right, there's synergy, right? Each one of them on its own does well, but when we combine them, we see statistical significance compared to essentially the comparator, which is TNF. So that's why the phyto blend, we think, decreases the inflammation so well. We see that by decreasing inflammation in vitro. Here we have a confocal microscopy study, 27 female and male patients with oily skin that are acne prone. We see 6-week single center clinical study. Again, it used twice daily, and confocal microscopy was used here to look at the hyperkeratinization in the follicular ostia, in the pores. Now, the number of non-inflammatory lesions decreased over time. Not surprising. We have some azelaic acid in there as well as arbutin, so we're getting some reduction in the comitogenesis, but we also see the hyperkeratinization and pore size reducing. And if you look at the confocal microscopy, each one of these follicular ostia has the white, which is the hyperkeratinization, those cornea sites that are adhering, and one of the reasons we get the microcomedones. Well, continued use through week 6, and we see that white really decrease. So we are affecting the keratinization with that phyto A plus, perhaps via that azelaic acid included in there. And so really interesting that we're showing at the level of confocal microscopy the decrease in keratinization using this product twice a day in the follicular ostia. Here's another study which shows the combination of CE ferulic, which is a the kind of headline product for SkinCeuticals, plus the hydrating B5 gel, together are not only well tolerated when used in conjunction with a microneedling treatment, but actually decrease downtime as well. And if you look in the far right, erythema, dryness, and tightness, day 15 post microneedling, by day 29, 2 weeks later, no tightness. Every blue is none. You want to see more blue. So no tightness, no dryness, very little erythema as well. So again, be aggressive with your skincare. I think what you think may not be tolerable after a non-energy based device treatment would surprise you. And I urge you to try things that may be out of your comfort zone based on the data that's available. Because I think what you're going to see is this integrated skincare enhances patient comfort as well as success. So in conclusion, the algorithm provides clinicians with recommendations when treating non-energy based and injectable facial treatments to stimulate healing, reduce downtime, and improve comfort. This was all based on a structured literature search. Clinical studies that were read and examined were used to inform our decisions and help us come up with this algorithm. Procedures combined with skincare or topical treatments improve skin condition. And by skin condition, I mean not only the condition of the skin, perhaps the hydration, the moisturization, all of the elements of skin health, but also the skin condition, meaning rosacea and acne, and maybe even atopic dermatitis. Skincare can help with that. Dyschromia is also an issue for richly pigmented skin. Topical antioxidants and free radical quenchers can protect against that. And the use of hydroquinone remains controversial. And as I mentioned, there are wonderful alternatives, that are available. Okay. Now, I wanted to give a shout out, please, to our advisors in this panel, Dr. Valeria Campos from Brazil, Dr. Sabrina Fabi from California, of course, Dr. Ginn, myself, Dr. House from England, Dr. Harvey, wonderful dermatologist in Virginia, and Dr. Tremblay in Montreal. We all came together and kind of put our brains together and came up with this algorithm, which I hope has been helpful. And of course, thank you to SkinCeuticals, which is the #1 medical aesthetic skincare brand worldwide, which granted the funds to make this happen. So thank you very much, SkinCeuticals. And now I'd like to leave a little bit of time for questions if possible. And I know Dr. Ginn is still available to help us.
So again, if you want to submit a question, use the question chat pane on the right-hand side of your screen, and any additional questions can be sent afterwards to info@rbcconsultants.com. So we're going to go to see if there's any questions. We have one question. We are trained to be pretty aggressive with using topicals to prevent PIH when treating darker skinned patients with lasers. How aggressive are you in using topical therapies to prevent PIH when treating patients with non-energy procedures?
So as I stated, I'm pretty aggressive because we can't minimize the effect that PIH has on patients' perception of success of the treatment. With all the new natural lighteners, Phyto A plus Bright is absolutely one of my go-tos, and I like to pair that with some of the other SkinCeuticals products like the Phyto corrective gel for the soothing effect. So I'm pretty aggressive. I do a lot of laser in my office, and it's not uncommon that patients will come in, just want a topical regimen, and then progress to some of these non-energy devices as well as laser. So I think it's a good general practice for patients when treating with any procedure, especially the microneedling.
I couldn't agree more. I love Dr. Ginn's statement, which is if a richly pigmented patient is dry, you are not going to have any success in reducing PIH. And so think about the products that you're using and ensure that they don't worsen the dryness. And I think that Phyto A Plus, I'm sorry, I agree. I think it's a wonderful product. It's super tolerated amongst all of my patients because of that Phyto blend, which mitigates some of the possible dryness with the azelaic acid, I guess. And it's a real go-to for me as well.
Is retinol ever included in the skin prep before service?
Lisa?
Yes, I do use retinol. You know, the main reason with patients for compliance, when you have patients stopping any of their topical therapies 3 days out, 7 days out, it breaks the continuity. And so I find that compliance is less. There's so many different options now with retinols that you can go from, you know, a milder form up to a harsher form. But as Ted was saying, I think we need to push the envelope some. You know, a lot of that data about using tretinoins and vitamin A is old data from ablative therapies. And with these non-energy devices, I think increased drug delivery is huge. And so I push the envelope and I balance that with the soothing agent like the phytocorrective gel, the CE ferulic, or the B5.
I don't have much to add, Roxanne. I think she's exactly right. I mean, there's data now to even show patients on Accutane do better when you add salicylic acid peels, right? And not high strength, but salicylic acid peels improve outcomes with patients on Accutane. So we need to start really thinking about how we can improve the outcomes by being a bit more aggressive with either drug therapy or with integrated skincare like that. And so absolutely retinol fits right in there.
Why do you think microneedling has become such a popular non-invasive treatment in doctors' offices after being offered so many years in spas?
I think there's so many different ways that you can do microneedling now, and it's a pretty inexpensive device for us to bring into our offices. You know, when you're talking about lasers, you're talking tens of thousands, if not hundreds of thousands, but a good microneedling pen is so much less expensive, so much less to put out to see a return on your investment. And then you can pair that with so many different topicals. You can do straight microneedling, you can do PRP, you can do really innovative topicals with microneedling, like some of the non-hyaluronic based biostimulators. That's something that's done in Europe. And I find that when you do microneedling, you have so many different indications, right? You can do it for under eye shadowing. You can do it for acne scars. You can do it for reducing fine lines and whatnot. So there's so much you can do with microneedling, and the learning curve is much more forgiving than with some of the more aggressive lasers. It's also cheaper for patients. So it's nice to be able to provide a full menu of services for patients, no matter what their budget allows for.
Agree. I don't have anything to add. I think perfect.
Do you recommend that patients avoid using pre-treatment products for a few days prior to undergoing in-office procedures to avoid potential irritation?
Go ahead, Lisa. What do you think?
I don't. Again, like Ted, I tend to push the envelope. If you're starting out and you're a little less comfortable with some of these procedures, you might say, okay, I'm going to have them stop the retinol, or I'm going to have them start stop some of the really strong fruit acids. But for the most part, these procedures, when done on a gradual scale, are so well tolerated by patients. I just don't think you need to stop the treatments beforehand.
Yeah, and in fact, I think by not stopping, you even out the stratum corneum, you may even out the thickness of the epidermis altogether, and you'll get a better result across the entire breadth of the facial skin. So, for example, if you are considering doing a TCA peel, right? That we do a ton of TCA peels. I'm a big peel fan. And I will have patients use retinol and alpha hydroxy acids up through the day before, because I know when I apply the peel, A, I probably will only need 1 or 2 passes of the peel to achieve really complete frosting, and B, it's going to be absolutely even across the breadth of the face, which gives them a better outcome as well. So I don't stop.
Wonderful. Well, that is all the time that we have with Dr. Lane and Dr. Ginn. Thank you so much for such an insightful and practical presentation for our listeners today or this evening. And thank you all for joining us. Good night, everybody.
Have a good evening, everyone.
Good night. Thank you, everybody. Thank you, Roxanne.
Thank you, Roxanne.
Thank you.